Welcome to another installment of our shoulder series here at PhysioDisc, where we will be taking a look at rotator cuff tears as well as labral tears and some of the differences between those, different grades, things such as that. And then we'll also look at either rehabilitative or surgical options, and then healing time frames and so forth. So stay tuned. This is sure to be a very exciting episode. So first we'll take a look at the rotator cuff. Now I know that in previous episodes we looked at the anatomy of the rotator cuff, and it's made up of 4 tendons that spell out an acronym SITS: supraspinatus, infraspinatus, teres minor, and subscapularis. Now those all have their own certain functions. Again, we have talked about that a little bit. Just to review, the supraspinatus helps to pull the humeral head up into the glenoid fossa or the shoulder socket. It also helps with the first little bit of this abduction moment here until the deltoids kick in and finish that out. Infraspinatus helps in external rotation of the humerus as well as the teres minor. So infraspinatus and teres minor both do that external rotation, and then subscapularis does internal rotation. Now, those are not the only muscles that do all of those things, but they definitely assist in those things, especially when you think about internal rotation. That's going to need a bigger muscle than just the little subscap. Now, the functions of these muscles are based on their origins and insertions. And I don't know that we have looked at photos of this before, but we're just going to review really quickly. When I said that supraspinatus helps with abduction and pulling the humeral head up into the shoulder socket, just take a look at where it's located on the shoulder there. But just by given where it's located in the body, it makes a little bit of sense as to why it does what it does. Same thing with infraspinatus, and then the same thing with teres minor, just where they're located on the humerus itself, and subscapularis too. All of those tendons are anchored onto the humerus in such a way that they are able to move that humerus in the way that it needs to be moved. Globally, they function for stability. So their main role is to stabilize the shoulder, not necessarily movement, but stability. Now, the tears to those tendons occur after long bouts of poor mechanics that are generally caused either by instabilities that have led to compensations or just general instabilities that are, again, left untreated. And the rotator cuff tendons are not the only ones that can often cause problems with the shoulder. I mentioned this before, but the long head of the biceps tendon also plays a huge role in stability at the shoulder. That too can become injured, but that's generally, again, because of poor instability at the shoulder, some type of improper loading of that tendon due to the rotator cuff's lack of cooperation. The labrum is a cartilaginous cup that sits inside of the glenoid fossa or the shoulder socket that really serves to kind of fortify the shoulder joint itself. What the labrum does is it serves to take up that excess space and to help the humeral head fit in there nice and snug and tight. And again, it can't do it all because it only fits around a portion of the humeral head at a time to make room for range of motion and things like that. So it has to have extra support from ligaments and tendons and a joint capsule and other things like that. And that labrum actually serves as an attachment site for several of those ligaments in the joint capsule. Now, there are different grades of tears that occur to the rotator cuff tendon. The full thickness tear refers to the complete tear of that tendon, and that generally happens in older adults, people who have had other rotator cuff injuries, maybe not full thickness tears, but they've had some type of partial tear previously, or if they've had multiple exposures to some type of corticosteroid or cortisone injection to the shoulder to help decrease inflammation from previous injuries. Partial thickness tear refer to just a little bit of tear that occurs in that tendon, and those generally happen to younger people or people who have not had multiple or previous shoulder injuries and are usually the type that are to be repaired surgically. Now, there is evidence to indicate that conservative care for rotator cuff tendon tears is plausible and is possible. And what I mean by that is to stabilize partial tears by thickening the tendon up and keeping it from progressing any further. But for the sake of this episode, we're going to be looking specifically at surgical interventions, as these tendons are, especially for partial tears, are most commonly surgically repaired. Now, there are two types of injuries or tears that can occur to the labrum, and those are slap tears. I've talked about those before. SLAP stands for superior labral anterior to posterior tears. And that occurs when there is a tear at the superior portion of the labrum that moves from anterior to posterior. And the second type is a Bankart's lesion or tear, and that generally happens when there's some type of forceful dislocation or forceful removal of the humeral head from the joint socket, and that happens in the kind of the posterior-inferior portion of the labrum. So you think about the back and lower part. So I usually think bank means base, and that only leaves slap for the superior, or slap for the upper portion. With slap tears, recent research has shown us that our previous way of thinking about slap tears may be wrong. It's not totally been proven yet, but there's a couple of theories on how the slap tear occurs. Kind of the previous thought was slap tears generally happen in the overhead kind of throwing motion in overhead athletes. You come back, you cock the biceps contracting, or there's a concentric contraction of the biceps, long head of the biceps, that pulls on that long head of the biceps tendon that is kind of one with the capsule and the labrum. It kind of all meshes together up here. And then when there is a forceful elongation, so you are coming through and you are forcefully pulling that long head of the biceps into extension, there is a pull on that labrum, and that's what causes that tear. That's kind of the previous, probably most used or widely used explanation as to why that happened. The new research, or kind of a new way of thinking, is that's not necessarily what's happening. They're thinking that, yes, there is kind of an elongation of the biceps, but that's eccentrically controlled, and there's not enough force on there to pull the labrum. What they're saying is happening now is that when you're coming back into full external rotation, which, if you know in pitchers, a lot of them will get slap tears, they have excessive external rotation. They can really whip that arm back. And when they're back here in this excessive external rotation, and because of its location in the bicipital groove and that external rotation, the tendon has no choice but to give excessive or just too much pull and overload the labrum and tear it that way. There is also research to show that would back up that second idea, or the second notion, that pitchers who have that excessive external rotation, more so than others, are more prone to tearing. More often than not, the conservative approach is taken to help repair these types of labral injuries. And when you get somebody in who's got some type of labral tear and you are looking to rehab them, you're looking at either stretching tight muscles that are surrounding the joint, and then strengthening weak muscles around the joint to give that shoulder some stability, and then giving that labrum time to heal up, or kind of correcting some of those poor mechanics or things that they've developed, like compensations over time, just due to the instability. Now, there are all types of surgical repairs for the rotator cuff tendon. You got just a full-on rotator cuff repair, a tendon sleeve, you've got tendon reattachments, you've got tenotomies, so on, so forth. In most cases, there's a lot of debridement that happens, and that debridement essentially just means that they've gone in and they've cleared out the bad tissue, the tissue that's not worth saving. Then they'll take care of any excess tissues or scar tissues that may be impeding normal movement, and they'll also remove any type of bone spurs or osteophytes if they find those. So the overarching goal, though, is to free up space within the joint. Anytime you have torn tissue, bone spurs, scar tissue, things like that, it decreases the space for those tendons to move around in the shoulder joint, and therefore makes movement more difficult and kind of produces what I like to call a sticky shoulder. The surgery is hopefully going to fix that. I think it's super important to note that surgery is by no means a cure. Anyone that I have treated, or anyone that I have seen who's had previous rotator cuff repairs and then been treated through therapy, their shoulders aren't perfect after that. Some people have really great results. They get up even to 98%, right? But it's not ever gonna go back to what it was before. That makes sense, right? They can repair what's going on in there, but they can't fix that some of that tissue isn't great anymore. You can't change the tendon quality. You can't change the tendon health. Because it makes sense, right? If the tendon quality was poor before going into surgery, no surgeon, no matter what they're gonna do after surgery, is not gonna make that tendon better. It depends really on the patient and therapy and things like that. And there are also some things that are out of our control. Now, healing time frames are also going to vary because there are many things that are involved in the rehab process, especially after a tendon repair. But you are looking at least from anywhere from 3 to 5 months, depending on your surgery, and maybe even longer, in most cases longer. And that's not necessarily getting back to throwing. That's just getting to a point where you're starting to get a lot of that range back, and you might start to think about doing some more functional activities. It really may be a year or more before you're ready to get back to throwing if you're needing some type of surgical repair to that tendon. And when you're looking at surgical repair for a labral injury or a labral tear, a lot of that varies really on the extent of the damage, kind of the mechanism of injury. And those things will not only impact your healing time frame, but also aftercare in therapy. Now, if you have the option, or this is something that the surgeon is wanting to do, if they're going to do it arthroscopically, which means much smaller incision, much less invasive, generally your healing time is faster and you're looking at a lot less pain overall. And conversely, an open surgery, as they like to call it, where they literally open you up, that's going to take a little bit longer to heal just because of the increased amount of controlled trauma. You're also probably going to have a little bit more pain with that. As far as healing times go with these labral repairs, those are very difficult to determine. And again, that's based on lots of different factors, but you are looking at least about 6 months, if not a year, before you're getting back to some of those functional activities. And that does not necessarily include throwing. As always, we're going to look at some special tests that physical therapists and even sometimes surgeons will use in their evaluation to determine whether or not you have a full thickness tear or a partial thickness tear to your rotator cuff, or even a labral tear. Now this is going to be a little bit different in this episode because this is the time when I say that if you think that you have a full rotator cuff tear or a partial rotator cuff tear or even a labral tear, that you need to go and be evaluated by a professional. A YouTube video is not enough. And I know that I'm kind of shooting myself in the foot there, but in order to get a really accurate test, you need to be going to see a professional who can gauge that for themselves. Because unlike muscle strains and some of those other things, mild tendon injuries, ligament injuries we've discussed previously, assessing your own rotator cuff tear or even labral tear is really difficult to do. So I would urge you, if you think that you have one of those, to please schedule to see your doctor, or if you're in a direct access state, such as Colorado or something like that, go and see a therapist and have them assess that for you, because that's just the safest route. Now, generally, if you have a full thickness tear of your rotator cuff, the action of that tendon will be difficult to do, and it will be relatively pain-free, especially if that muscle is one of the main movers in that action. Because if you think about it, the tendon's torn. There's nothing to hurt because the damage has already been done, and it shouldn't be able to do its job because it's fully torn. Like the connection is not complete, so that pulley system doesn't work like it should. Or there will be some type of excessive compensation. For instance, one of the signs for supraspinatus tear is called the shrug sign. And that doesn't mean like, hey, shrug your shoulders, can you do that? That means when you ask them to abduct their shoulder or abduct their arm, if that supraspinatus is torn, it can't pull the humeral head up. So a lot of times what people do to compensate is they will shrug before they do it, or to help get it up. Or conversely, or if you bring their arm up and then ask them to slowly lower it, oftentimes they will shrug their shoulder to help lower it before it goes all the way down. Again, because they don't have an intact supraspinatus. For tears to the labrum, either a slap tear or a Bankart's lesion, there are a few very popular tests. And generally for the slap tears, you're looking at some type of biceps loads test. It should be done in various positions, I'll show you one example here. And then we're also for looking at some type of anterior instability in terms of those Bankhart's lesions, because remember, those generally happen with dislocations. So let's go ahead now and take a look at what those special tests would look like. For the sake of time and for the sake of overwhelming you with information, or just kind of useless bits of information that as a patient you may not need to know, it doesn't make a lot of sense to me to go into those minor details. So what I will do is just kind of give you a general idea of what to expect if you think that you are, or if you are headed into surgery to fix a rotator cuff or labral tear. First, you're going to be immobilized, and what immobilized means is that you're going to be put in some type of sling, and it's generally an abduction sling, which kind of holds your arm out to 30 degrees abduction, and then your elbow is also going to be bent. You're going to be that way for a little while, and that's to allow for healing and then to prevent any type of active range of motion occurring at the rotator cuff or at the shoulder that might disrupt healing of the rotator cuff or the labrum. After you've been immobilized for some time, and sometimes it's even of just a few days after surgery, you're going to be going to therapy to do some type of passive range of motion. And passive means that you are not doing it yourself. That means you're going to lay down on a table and a therapist is going to move your arm around, and they're generally given guidelines to the amount that they're able to move your arm. Sometimes it's your pain as the barometer. Other times it is you can't flex your shoulder past 90, or you can't externally rotate past 35 at neutral. Also, your therapist will probably give you some type of passive range of motion exercise to do on your own at home, like a pendulum arm swing. Or sometimes I know people who have had a tenodesis. I'm working with a guy who's had a biceps tenodesis. At home, he got a constant passive range of motion machine that literally he hooks his arm up to, and the machine moves his arm around for him, which is really pretty neat. And this is all done in the sake of preventing the buildup of excessive scar tissue. Generally, after surgeries, that shoulder capsule is pretty tight just because of immobilization and because there's been trauma to the shoulder, and they want to avoid that capsule getting too tight. You're also going to be doing a lot of icing. They're probably going to tell you to ice it anytime you think about it. General guidelines for icing are from about 15 to 20 minutes at a time, taking about an hour in between break. Sometimes they tell you to ice 5 times a day, whatever. Just generally listen to what your surgeon has to say or what your therapist tells you to do. And that's done for decreasing inflammation and decreasing pain. I know a lot of people think, well, isn't that inflammation kind of good for that joint? Because, there's blood going there and things like that. I'm sure, but it's also gonna be really painful. So it's gonna heal regardless. But what you're not going to want to do is you're not going to want to move or do therapy type things if you're in too much pain. So listen to your therapist, listen to your surgeon, and do that icing. Now, once passive range of motion has been restored, they usually look for full, or again, therapists will have certain guidelines or numbers that they want to achieve before they'll move on. But what you'll look to do is to start doing some type of active assisted range of motion. Active meaning some of the activity, muscle activity, will be your own on that operative side, but the rest of it's going to be helped usually by your non-operative side, or sometimes they use canes or pulleys or other types of devices just to help you help yourself get that range back. And this is done to start to load the tendons like they need to be loaded, but also to protect them. They're not ready for full work yet. They're not ready for full duty. And then once active assisted range of motion and passive range of motion are no longer an issue, you're going to start doing some type of active range of motion, generally starting with some type of isometrics at the shoulder. I give a lot of patients shoulder isometrics to do at a doorway. We've done some of those in some of the rehab videos. And you're really just looking to get deltoid activity and rotator cuff activity restored. Start to get those muscles firing again. You also look to be doing some type of scapular stabilization because the shoulder blade articulates and is such a big part of shoulder movement. You're going to be looking to get those periscapular, or those muscles surrounding the scapula, strong, get them some endurance, and just get them working like they should be again. And then finally, you're looking at adding some type of functional activity. If your goal was to get back to golf, you may start by swinging a broomstick, right? It's not a golf club, a lot lighter, but it's functional range. Then you may move to a really light club, just one-armed, right? And then you may move to 2 arms, and then you may move to hitting a practice ball. Then you may move to hitting an actual ball. Then you may move again to like chipping, and it's always a slow progression. But the last activity or the last stretch of therapy is looking at functional activity. And then you are looking at probably your discharge based on whether or not you've met certain range of motion and strength goals that have been predetermined between you and the therapist, or by the therapist, or whatever protocol or guidelines that they're using. Now, let's talk prevention. If you look online, there's lots of people who say, hey, bulletproof your shoulders, or here's the magic pill for shoulder, injury prevention. That does not exist. Our sport does not exist in a vacuum, and it is not free of things happening, right? No sport is. I mean, you look at professional athletes in any sport, they're injured all the time, and they're working with the best trainers, the best sports physical therapists, the best doctors, the best surgeons, the best nutritionists, best strength and conditioning coaches. They have the best of everything, but they are still getting hurt. So it's impossible to prevent injury. It just is. But they are also a lot less likely to get injured because of all of those benefits they have of working in prevention, either through therapists, doctors, diet, strength and conditioning, whatever. There are some things that you can do to decrease the likelihood of you getting injured, but again, there is no 100% surefire way to keep it from happening. Your best bet is to make sure that you are working on some type of endurance building or stabilization exercise regimen for your shoulder girdle. And what I mean by your shoulder girdle is not just your rotator cuff, but your periscapulars, your pectorals, biceps, triceps, things like that, lats. Really, you just need to be working out, and you need to be doing things that are geared toward treating overuse injury, which is the most common at those shoulders, which fortunately for you has all been covered in previous episodes. And I've given you exercises, I've given you reps and set ranges, given you a lot of good ideas. As always, if you have questions on other things that you can do or you could do, please feel free to message me or leave a comment below, ask any kind of question, and I'd be happy to help you out. Again, if you feel like something isn't quite right at your shoulder and it is lasting more than a week, more than 5 or 6 days, get it looked at by a professional. Stop throwing and get it looked at. It is not worth playing through if you could be looking at surgery, because like I said before, you may be out a year or more because you decided to play through it. You don't want that. You don't want that. You don't want that to impact the progression of your game or the involvement in tournaments and fun things that you're liking to do. There's no shame in getting peace of mind about something that you suspect may be an injury. Worst case scenario, it is an injury, and you've got to try to rehab through that. Best case scenario, there's nothing to worry about, and you can continue playing. But if you have your doubts, please get it checked out by a professional. That's it for this episode. I really hope that this was helpful and informative for you, those of you watching. I also really hope that no one is looking at surgery as they're watching this or getting too freaked out. Again, if you have your doubts, please go get checked out by a professional. This is the second to last episode in this shoulder series. The last one we're gonna look at is impingement. That's gonna be a really fun episode. I promise to have a little bit more in terms of therapeutic rehab and some things that you can do to kind of help mediate your own symptoms and pain with that. But as always, if you like what you see here, like, share, subscribe. Tell folks about PhysioDisc if you know somebody struggling with something going on with their shoulder or anything else like that. If you have any questions, please reach out to us either on Facebook, follow us on Instagram. You can leave comments and questions here as well. And as always, stay excellent.